Hi, my name is Michelle Stram, and I'm a senior medical examiner at the New York City Office of the Chief Medical Examiner. And I'm going to talk to you today about a forensic pathologist's approach to the molecular autopsy. We're going to cover a number of topics today, including understanding the role of the forensic pathologist, what the molecular autopsy can bring to forensic pathology, pre-autopsy and investigative considerations, findings at autopsy to guide molecular testing, integrating the molecular results with the other autopsy results, speaking with families about the molecular and autopsy results, and sharing our experience with other providers. Forensic pathology, whether it is taking place in a medical examiner or coroner system, is a team effort. Forensic pathologists are specialized physicians with training specifically in determining the cause and manner of death. These are doctors who did residency training in pathology, followed by fellowship training in forensic pathology. Many forensic pathologists also have subspecialty training in neuropathology, pediatric pathology, or cardiovascular pathology, or forensic pathologists work closely with pathologists who have subspecialty training in these fields. In our office, the medical examiners work closely with a large and diverse team, including our medical legal investigators, toxicologists, molecular genetics laboratory and our genetics counselor, anthropologists, radiologists, as well as infectious disease and microbiology specialists and clinicians in other branches of medicine. For some level setting, it is important to understand what the forensic pathologist is tasked with doing. The forensic pathologist is responsible for determining the cause and manner of death. The cause of death is the disease, injury, or the combination of diseases and injuries responsible for initiating the lethal sequence of events and without which the death would not have occurred. The cause of death should not be confused for the mechanism of death. The mechanism of death is the alterations in physiology and biochemistry that's responsible for the terminal events, and these can result from many different underlying conditions. So mechanisms of death would include sepsis, a cardiac arrhythmia, and asphyxiation, and these mechanisms are never etiologically specific. The manner of death is how we categorize the death, and manners of death include natural, accidental, suicide, homicide, or undetermined. Performing a molecular autopsy offers a number of advantages for the forensic pathologist. It can provide an etiologically specific cause of death. It can give us the opportunity to provide more precise answers for the grieving families that we serve. The results from the molecular autopsy can be a point of intervention for other family members so that living relatives can undergo targeted testing. And the molecular autopsy can help us to improve public health and vital statistics, as well as to add to the medical literature and inform other doctors and providers who may see patients that are at risk for sudden and unexpected death. In the forensic setting, we are focused on molecular genetic testing, which may provide an underlying cause for sudden and unexpected death. We have several molecular genetics panels. We have a cardiac focus panel, which includes cardiomyopathies and channelopathies, an epilepsy focus panel, including epilepsy syndromes and conditions that feature seizures as a symptom, an aortopathies panel, and a thrombophilias panel. It is important to understand that identifying cases which will benefit the most from a molecular autopsy is a multi-step process, and so this is a slide that we will return to. The process really begins before the autopsy with a thorough death investigation, and there are many pre-autopsy considerations. Then the pathologist needs to perform a thorough autopsy and determine what ancillary studies and subspecialty services may be needed for that case, and also save a specimen that will be suitable for molecular testing. The pathologist then needs to determine what ancillary studies should be performed, and the results of these studies may support or refute the need for molecular genetic testing in a given case. The importance of the pre-autopsy and investigative considerations cannot be overstated. Performing a comprehensive investigation into the circumstances surrounding a death, including a thorough scene investigation, interviews with family and friends, family and social histories, obtaining a medical history from treating clinicians when applicable, and reviewing relevant medical and/or hospital records can provide the pathologist with a plethora of information that can allow them to develop a differential before coming into the autopsy room. And this differential can help guide the molecular genetic testing if needed. I'm going to take you through some examples that underscore how important the investigative components are when approaching molecular genetic testing. So in the first example, we're going to talk about an apparent sudden cardiac death in a young person. And for this, it's really critical that the medical legal investigator ask detailed questions about the decedent's medical history. But more than that, it really needs to include specific questions such as if the decedent experienced dyspnea, palpitations, or episodes of syncope, understanding the specific relationship between any symptoms the decedent had and their physical activity, asking about a family history of sudden death at a young age, and a family history of known cardiac conditions that manifested before middle age. There are many resources which medical examiners and coroners can use to identify questions that they would like their investigators to specifically ask. And it is extremely beneficial and well worth the effort to work with your medical legal investigators to put together a standard operating procedure of the questions which need to be answered in cases that are suspicious for sudden cardiac death. The Cardiovascular Pathology Society published a consensus statement with recommendations for how a forensic pathologist should approach cases of sudden cardiac death in young decedents, including the types of questions that will provide critical information for the forensic pathologist to be able to develop a well-founded differential prior to performing the autopsy. This publication is useful not only in developing standardized questions for the investigators, but it also includes recommendations on gross examination and ancillary testing in these cases. Another resource which may be helpful for medical examiners and coroners to review and to extract questions from when they are seeking to create standardized operating procedures with our medical legal investigators is the Investigative Guide and Family Interview Tool, which is freely available from the Sudden Death in the Young Case Registry. The second example for pre-autopsy and investigative considerations is epilepsy and non-traumatic seizure disorders. In these cases, it's important not only to ask detailed questions about the decedent's medical history, but to obtain a specific seizure history. In addition, it is important to clarify that the seizures are natural as opposed to post-traumatic, and to determine if there's any association with substance use, alcohol use, or substance withdrawal or alcohol withdrawal. It is important for the investigator to ask questions about the age of onset to determine if the decedent had a history of childhood febrile seizures, and to document the seizure frequency, including the presence of breakthrough seizures while on medication. It is also important for the medical legal investigator to ask about the decedent's epilepsy medications and their compliance. The investigator should ask about what medication specifically the decedent was prescribed, the dosage of the medications. The investigator should identify dates from the refills, perform a pill count, and record the prescribing physician. The investigator should ask if the decedent had any surgical interventions. If so, what procedures were performed, where were they performed, and when were they performed? And the investigator should also ask about comorbid conditions, including cardiac findings such as syncope or any psychiatric history or cognitive impairment, which may help the medical examiner identify an appropriate differential for the case. Medical legal investigator should include questions about a family history of seizure and related disorders. And in cases of suspected sudden death and epilepsy, it is especially important to document any relationship between the death and sleeping. So the medical legal investigator should specifically ask if the decedent was last known alive, sleeping, to document the position of the decedent, as well as the placement of the nose and mouth. There are a number of excellent resources which medical examiners and coroners can use to identify questions in conjunction with their medical legal investigators to specifically ask in cases of suspected death related to epilepsy. This publication from the Academy of Forensic Pathology on the investigation of deaths in seizure patients provides an excellent starting point for developing such a questionnaire and includes information on the death investigation, as well as autopsy considerations and ancillary testing for these cases. The National Association of Medical Examiners released a position paper with recommendations for the investigation and certification of deaths in people with epilepsy. In this paper, they provide guidance on the types of questions which should be included when developing a standard operating procedure for the medical legal investigation of cases of epilepsy. In addition, they provide guidance on appropriate ancillary studies and the interpretation of the integrated results of both the investigation, autopsy, and ancillary testing. The third example for pre-autopsy and investigative considerations is the approach to sudden, unexpected infant and childhood deaths. These are some of the most challenging cases which forensic pathologists are tasked with working up and may benefit tremendously from molecular genetic testing. There are resources which can help medical examiners and their medical legal investigators to develop a standard operating procedure for approaching infant and pediatric deaths. The Sudden Unexpected Infant Death Investigation Reporting Working Group developed a Sudden Unexpected Infant Death Investigation Reporting Form, which illustrates the types of questions which should be asked and elements of the scene investigation which should be thoroughly documented. These include the infant's age, as well as the gestational age at birth, the birth history, the decedent's medical history, any recent health changes, as well as information about the maternal pregnancy history, relevant family history, including any history of infant or pediatric deaths, and also very specific attention to the scene, including the relationship between the death and sleep, prone positioning, placement of the nose and mouth, the type of bedding which is present, and other details. By having a thorough death investigation, which is tailored to recognize sudden and unexpected causes of death, which can have an underlying genetic etiology, the forensic pathologist is in a much better position to think strategically about the differential for a given case. And it allows planning for ancillary studies which can be reasonably anticipated to be needed prior to beginning the autopsy. It also ensures that the forensic pathologist is considering appropriate conditions, and information about family history can also raise the concern level for a potential genetic cause of death that might not be readily appreciated without this information. Once the forensic pathologist is performing the autopsy, they also need to be cognizant of gross findings which suggest a diagnosis that would benefit from genetic testing. Even if the forensic pathologist has limited experience with these entities, a high index of suspicion from the investigation history and recognition of gross abnormality may be enough impetus for the pathologist to request subspecialty evaluation, such as cardiac pathology consultation, and to ensure that appropriate specimens are saved for molecular testing if needed, and that appropriate companion diagnostics are ordered. Inherited aortopathies represent another set of conditions where molecular genetic testing is invaluable both for understanding the underlying cause for the death and because the testing can provide a potentially life-saving point of intervention for affected relatives. Inherited aortopathies are conditions that can predispose affected individuals to a mural weakening and dilation of the aorta, and although the diseases may be silent, they can also result in sudden and unexpected death due to dissection or rupture. The thoracic aorta, as the most proximal portion of the aorta to the heart, withstands the greatest wall stresses and the highest pressures. The ascending aorta and aortic root are embryologically distinct from the remainder of the aorta, which is the descending thoracic and abdominal portions. Thoracic aortic aneurysms most commonly involve the ascending aorta, followed by the descending aorta, and can be commonly divided into syndromic disorders with extravascular organ involvement, or non-syndromic disorders, where the aortic abnormality is seemingly isolated. Familial thoracic aortic aneurysms are non-syndromic. Syndromic disorders include Marfan syndrome, type 4 vascular Ehlers-Danlos syndrome, and Loeys-Dietz syndrome. For example, a medical examiner may be presented with a case of a tall, thin young man who had chest pain radiating to his back, who suddenly becomes unresponsive. This history immediately calls to mind the potential for an aortic dissection. Because these cases may not be encountered frequently, it is very helpful to review the systemic features of the syndromic disorders to ensure that evaluation of these features is documented in both the external and internal examination. For example, knowing to look for and document the presence of bifid uvula, which can present in people with Loeys-Dietz syndrome, may not be top of mind without taking the time to review the features that characterize this condition. Likewise, documenting not only the height in suspected cases of Marfan syndrome, but also the upper segment and lower segment ratio and increased arm span to height ratio can facilitate an informed differential for what syndrome may be present. And this also allows for genotype-phenotype correlation in cases where molecular genetic testing is performed. In all of these cases, the history and autopsy findings can raise a red flag for the medical examiner that the case may benefit from molecular testing. In cases of cardiomyopathy, it is likewise helpful to be familiar with the gross features that can result in sudden death in young people, and even in cases where the medical examiner may not immediately recognize the entity. Recognition that the heart is abnormal and that the case may benefit from cardiac pathology consultation can still support identification of the correct diagnosis. In the two examples shown on the screen, the gross findings alone warrant the request for molecular genetic testing. These are textbook features of arrhythmogenic cardiomyopathy. The case on the left shows a subepicardial concentric ring of fibrosis of the left ventricle, and the case on the right shows fibrofatty replacement with transillumination of the right ventricle. A contemporary review on the evolving diagnostic criteria for arrhythmogenic cardiomyopathy was published in the Journal of the American Heart Association and provides both clinical and pathologic features of arrhythmogenic cardiomyopathy. Recognizing these striking gross findings also immediately allows the medical examiner to have a working list of genes in mind that they anticipate may contain a variant. And it again allows the medical examiner and the molecular geneticist to make a genotype-phenotype correlation. By this point, you can appreciate that there are many factors in the investigation and autopsy examination that can strongly indicate the need for molecular genetic testing. That said, all deaths that are sudden and unexplained, where the cause of death is not clear at autopsy, benefit from having an appropriate specimen retained for possible molecular genetic studies. Cases that should raise this concern include drownings where the decedent is sober or was an experienced swimmer, a single motor vehicle accident where there's a concern for a natural event initiating the chain of events, an unexplained death of an individual with a family history of sudden death or family history of inherited heart disease, any cardiomyopathy identified at autopsy, or any unexplained seizure in a young person. In all of these cases, there is ample evidence to save postmortem samples for genetic testing. And the National Association of Medical Examiners has provided a position paper on retaining postmortem samples for molecular genetic testing when needed. In the forensic setting, the companion diagnostic information provided by molecular genetic testing can enable the forensic pathologist to identify an etiologically specific cause of death in cases of cardiomyopathies, channelopathies, and non-traumatic seizure disorders. Molecular genetic testing can also help to identify the underlying cause of an aortic dissection and a pulmonary thromboembolism in instances of genetic aortopathies and hereditary thrombophilias, respectively. In all of these cases, it is appropriate to save a specimen for possible molecular genetic studies. This could include 5 to 10 milliliters of blood in a lavender top tube, or fresh tissue and a nucleic acid stabilization and storage solution. In both cases, these types of specimens can be stored in minus 20 degrees Celsius in a freezer indefinitely. Although a blood spot card is not an optimal specimen, it has the advantage of requiring very little space, readily available storage conditions, and this may become more important when thinking about the longevity of specimen retention for future molecular genetic testing. Determining the cause of death is a multi-step process and integrates information from the death investigation, the autopsy, and the results of the ancillary studies. These results then need to be integrated and taken into account with any molecular genetic testing results. Integrating the molecular results into a cohesive explanation for a decedent's cause of death is critical. The structured autopsy report includes a list of final diagnoses and also documents the ancillary studies which were performed. In cases where the molecular genetic results fundamentally underpin the underlying cause of death, there is a strong case to be made for including the molecular genetic results in the final diagnostic list of the autopsy report itself, in addition to the separate molecular genetics report. The approach that I have to death certification is similar. In all cases, I imagine, what if a family has only this single document, whether it is the death certificate or the autopsy report, and they hand that document to a clinician? Is that document providing enough information for the clinician to understand the key diagnostic information, including the disease and gene implicated, which are responsible for the cause of death? To consider it a standalone document, I advocate that the gene responsible be included on the death certificate. The value of this is multifold. If all the family has is the death certificate, having the molecular genetic results conveyed with the cause of death is still tremendously informative for any clinician, and it can also help to provide important information for vital statistics. The molecular genetics report itself serves two main purposes. The first is the communication of the molecular genetic results in lay language that is meaningful for the family. The second purpose is to communicate to clinicians and other providers the specifics of what testing was performed, how the interpretation was rendered, and what the results mean. Perhaps most important for families, though, is the genetic counseling component to molecular genetic testing. The genetic counseling report generated by the genetic counselor also provides critical information back to the forensic pathologist and can provide a holistic sense of the disease which may potentially impact multiple members of a family. My approach to speaking with families in cases of sudden and unexpected death or cases where I strongly suspect a potential genetic component are multifold. On the day of the autopsy, I explain the gross findings, what I am most concerned about, and what studies are pending. And if it will be a stepwise progression for the ancillary testing, I explain how I will make those decisions. When the molecular genetics results are available, ideally in the context of the complete autopsy results with all ancillary testing. I contact the families again and review the autopsy, ancillary testing, and molecular genetics results. At this point, I also offer that they speak with our genetics counselor. In cases where the molecular results identify a pathogenic or likely pathogenic variant, even while I have other ancillary testing pending, I reach out to families and explain that there are many studies still pending, but the genetic results are available and they have identified a variant or a mutation which may be of importance to the family, and I suggest that they speak with our genetics counselor. In all of the cases I've had as a medical examiner, the families have been overwhelmingly and tremendously appreciative of the opportunity to speak with our genetics counselor about what these results mean for them and what the next steps are for their family. Molecular genetic testing is an incredibly valuable tool in the types of cases that medical examiners and coroners see on a daily basis. However, this testing is not available to most providers, and so it is important for us to bring our experience to medical society meetings, in peer-reviewed publications, in professional society guidance documents and position papers, and to increase interdisciplinary efforts to increase the postmortem genetic testing available for decedents and for their families. I'm going to share two cases with you which illustrate to me the incredible value of molecular genetic testing in the forensic setting. The first case is a 37-year-old man. He has a past medical history that's only notable for obesity. He has no history of alcohol use, tobacco use, or substance use. He was having a conversation with his girlfriend over video chat. She states that he was behaving normally and had no complaints. He tells her that he's going into the kitchen to get a snack, and 10 to 15 minutes later, his girlfriend checks the video chat and sees him on the floor unresponsive. She immediately calls EMS, and they arrive and transport him to the hospital with ACLS in progress. The emergency department staff continue resuscitative efforts, but they're unable to revive him, and he is pronounced. The history itself puts a cardiac cause of sudden death on the differential diagnosis. In performing the autopsy, the most striking finding in the case was a markedly dilated heart, which you can see here. Ancillary testing was performed in this case, including a respiratory virus panel, full histology, including a myocarditis workup. Tissue was saved for molecular genetic studies, including cardiac tissue and RNA later, in addition to our standard blood spot card. Full toxicology was performed, vitreous chemistry was performed, and the family history was reviewed. The family history revealed that there were several sibling deaths, including the decedent's sister, who died at age 25, 4 days earlier, and the decedent's brother, who died at age 26 in 2013. In this case, all three autopsies were performed within the New York City OCME system, albeit by different pathologists at different borough offices. Nonetheless, this allowed me to immediately review the three cases together. The gross photographs of the hearts from the three autopsies are represented here. The photographs on the left-hand side are those taken of the 37-year-old decedent. The photographs in the middle are those of the 26-year-old decedent who passed away in 2013, and the photograph on the right is the 25-year-old decedent who died 4 days earlier. In all cases, there is striking cardiac dilatation and an apparent dilated cardiomyopathy. Presented here is a simplified schematic for the workflow of molecular genetic testing in our office. These cases are highly suspicious for an underlying genetic contribution to the cause of death. I alerted the other two forensic pathologists to the findings present in all three cases, and we reached out to the family to let them know that molecular genetic testing was underway and that we had a high level of concern for genetic contribution in these deaths. We obtained additional history from the family and determined that the two brothers were full siblings and that the sister was a half sibling. In all three cases, the siblings had a dilated cardiomyopathy. This is the molecular genetics report from the 37-year-old decedent. The report not only provides information for clinicians, but also a summary of what the family needs to know, including why the testing was performed, the inheritance pattern, the conditions caused or possibly caused by the variant that's detected, risks and recommendations for the family, as well as the contact information for our genetic counselor. The genetic testing identified a likely pathogenic variant in the 37-year-old decedent in the Titin gene. Retrospective testing of the 26-year-old brother who died in 2013 revealed that he shared the same variant in the Titin gene as his brother. Interestingly, a variant of uncertain significance was identified in the FLNC gene of their half-sibling sister, who also had a dilated cardiomyopathy. There are many ways to think about this case. We all wish that the testing had been available in 2013, or that there was unlimited funding for retrospective testing of old cases, because perhaps the variant could have been identified sooner and could have been a point of intervention before the sudden, unexpected death of the young man in 2022. Nonetheless, we were able to bring this knowledge to the family, and our genetics counselor was able to explain what these results mean for them and what the next steps are to hopefully prevent any other sudden, unexpected losses in this family who have already suffered so much grief. I also think of all of the medical examiner and coroner offices who don't have the capacity to perform this testing and who lack access to this testing, and what this means for all of the families that will never have this information. And that is part of what motivates us to share with you how important postmortem molecular genetic testing is. The second case is that of a 2-year-old girl with a history of febrile seizures who was found unresponsive in bed at approximately 8 in the morning when her father tried to wake her up. He called 911 and EMS brought her to the hospital where they continued resuscitation attempts, but despite their efforts, she was pronounced in the ED. The rectal temperature they recorded in the ED was 98.7 degrees Fahrenheit. The medical legal investigator performs a full scene investigation and obtains a pediatric history. The decedent resides at home with her parents, her sister, who's age 6, 2 aunts, and 3 uncles. Per the decedent's father, she was in her usual state of health without any complaints, and since it was spring vacation, the parents let the 2 girls stay up later than usual. The 4 family members share the same bedroom. The father states that he and the decedent's mother sleep together on one bed, and the decedent and her sister sleep together on the adjacent pull-out bed. The mother tells the medical legal investigator that the decedent has a history of febrile seizures since birth. She was on Keppra, which she took twice daily, once in the morning and once in the evening. The decedent's father stated that she suffered from seizures often. When she turned 1, she began to have seizures approximately 1 to 2 times per month. Approximately 4.5 months ago, though, the decedent started to have seizures less frequently. The mother states that the decedent's last seizure was approximately 4 months ago, and she had the decedent's medical history readily available for the investigator when asked questions. The mother states that she herself was born with epilepsy, and that both of her daughters were born with febrile seizures. She tells the investigator that there's no history of sudden death in infants or children within their family. The mother provides a birth history that the decedent was born at 40 weeks by spontaneous vaginal delivery without complication. She is up to date on her immunizations and has regular medical care. She did not have any recent symptoms, and she did not sustain any injuries. A complete autopsy is performed, including a careful external examination, internal examination, full histology, bacterial cultures, respiratory virus panel, gastrointestinal pathogen panel, comprehensive toxicology, vitreous chemistry, full neuropathology of the brain, dura, and spinal cord, and forensic imaging. Respiratory viral testing reveals human metapneumovirus, respiratory syncytial virus, and human rhinovirus enterovirus. Histology of the lungs shows focal inflammatory changes and rare multinucleated giant cells consistent with viral cytopathic effect. The remainder of the histology is negative for significant pathologic change, and there is no evidence of myocarditis. Full neuropathology was performed, which revealed bilateral mesial temporal sclerosis, as well as features of cerebral dysgenesis. In addition, there was focal sparse perivascular leptomeningeal mononuclear infiltrate identified on histologic sections. Molecular genetic testing with the epilepsy-focused panel revealed that the decedent had a pathogenic variant in the SCN1A gene, which is a known cause for seizure disorders. I will leave you with one final thought. Forensic pathology is a team endeavor. We are very fortunate to have our colleagues in molecular genetics because, as you have seen, they play a critical role in helping us to provide the best answers we can for the families we serve. Thank you.